سريع.
Old age female with a non-chronic disease presented for follow-up. She is on يعني follow-up, regular follow-up, coming to regular follow-up because she is a non-case of chronic disease.
أوكي.
مريم عليك كيفك ترى انت تقمز السلايسات كل ما نشوف
آسفة أستاذ.
يعني سلايس ويطلع وراه يلا امشي. ما خنسى شفتي شيء؟
دكتورة نصعد فوق على المسامات السبرين والليفر.
مريم هاي انت جايبت لنا الارتريال 1 مليم والبقيه كلهم 5 مليم، فلهذا دا يصير discrepancy بالسلايسز.
discrepancy بين
نعم
اي
أستاذ نعم.
يعني هذا
أنا
الوحيد
خليت
جايب.
لها بري كونتراست والارتريال.
اي مو واحد جايبته 1 مليم الريكون والبقيه كلهم 5 مليم، فالواحد مليم
أي
كل
نعم
5
أستاذ.
سلايسات يلا سلايس بقد يصير بالواحد بال5 مليم.
نعم أستاذ.
نعم أستاذ.
هسه ايش تشوفين؟
This is a multi-section CT study with the IV contrast and oral contrast at the level of the upper abdomen. There is an obvious splenomegaly. يعني native أنا ما شفت فد abnormality بالليفر، بس early arterial there is hyper enhancing node يعني lesion in the right upper. دكتور سعد يعني at the upper segment of the liver يعني at segment 7 ماخذ يعني hyper enhanced at the early arterial phase. دكتور عندش ديلي؟
إيه هذا الديلي؟ هذا الديلي دكتور ما طلع.
نعم نعم صار.
شفت البورتال؟ انت غير تشوفين البورتال قبلها؟
طلعت لها البورتال وشافته.
شافته؟ اوكي.
ايه شافته.
اوكي استاذ. بالديلي صار عندنا وش اوت.
اي
واكو يعني بقى يعني الانهانسنج كبسول.
زين.
الليفر look normal apart from this lesion، يعني ما عندي irregularity بالكبسول، وما عندي هايبر يعني ما عندي اتروفي بال هايبر سيجمنتال hypertrophy or atrophy in the liver. يعني على مود واحد يخلي بباله مثلا انه هذا الليفر سيروتيك، فاحنا عندنا هايبر enhancing single lesion in the liver on background of normal liver. يعني هو أنا بالبداية يعني من قالت كرونيك ديزيز فكرت إنه احتمال سيروتيك، وإنه هذا
نعم.
الليجن هو
هو
يعني أول
شيء
consideration.
يسموه هذا الليجن اللي ياخذ ايرلي او ارتريال انهانسمنت ويصير بوش اوت بالديليد، شو يسموه؟ له اسم؟
يعني هو ما أعرف يعني، بس إحنا رأسا نخلي بالنا الهيباتوسيلولار كارسينوما.
لا شنو له اسم؟
يعني هو
مصطلح راديولوجيكلي سبيكينج شو نقول عليه؟
يعني يسوي يعني هو هايبر فاسكولار، ما أعرف أستاذ
هايبر
يعني.
فاسكولار. نعم تمام، كمل.
نعم أستاذ. فهو يعني هو سنجل في إما
ايه
يعني ميتاستاسيز يا إما خلي هايبر هيباتوسيلولار كارسينوما
ايه
as a differential diagnosis.
زين.
chronic disease يعني ما يعني الليفر نوت سيروتيك، ممكن
نعم
يكون يعني عندها viral infection ويعني regular interval screen ده تسوي
نعم.
البيشنت على مود هذا الشيء. يعني هو هذا يعني السيناريو الوحيد
والسبلينوميجالي شنو علاقته بالموضوع؟
السبلينوميجالي دكتورة شوفينا البورتال ممكن يكون نتيجة البورتال هايبرتنشن
يعني دخلتي بكرونيك ليفر ديزيز قصدي؟
هو بس هو
بورتال
الليفر
هايبر.
شكله نورمال،
لا
راديولوجيكلي نورمال.
ليه صار السبلينوميجالي؟ نرجع نسأل ليه صار السبلينوميجالي؟ عندها بعد غير شيء لو بس دني السبلينوميجالي والليفر ليجن، اكو بعد عندها شيء اخر؟
أنا ما شفت
نعم.
دكتور البورتال، بس يمشي على كيفك. ممكن يكون مثلا شوف إذا أكو كولاترالز. يعني ماكو بورتال ابنورماليتي،
نعم. فانت
والبورتال
هسه
شكلهم
برايك هذا لو
تقريبا within normal.
ميتاستاسيس، انت برايك لو ميتاستاسيس لو هيباتوسيلر كارسينوم
نعم
هالشكل يعني؟ عندك بعد
نعم.
اذر بوسيبيليتي؟
يعني ويا الكاركترستيك مال يعني الانهانسمنت، لا بس ذول الاثنين.
شو تريدين تسوي له بعد هذا، او شو تطلبين بعد تريدين تشوفين؟ شفت السيتي، شنو المطلوب تشوفين بعد حتى تاخذ الديسيجن اكثر؟
دكتور نعرف شنو الكرونيك يعني ديزيز اللي عندها البيشنت وعلى اساسه
عوفي
نطلب.
هذا السؤال.
زين.
ايميجينج، ريجاردينج ايميجينج، شو تطلبين تشوفين؟ الترا ساوند يفيدك؟
الالترا ساوند نعم استاذه، تشيك بيه البورتال.
نعم بس
يعني اشوف
البورتال تشيكين
البورتال
بيه؟
ما اعرف بعد يعني نشوف البورتال هايبرتنشن اذا اكو الويفز مالته.
شفت البورتال فين؟
الفلو.
شفتي البورتال فين؟ مو هذا البورتال فين قدامك؟
اي دكتور، بس بالدوبلر يعني شوف لنا اذا اكو early sign of hypertension.
نعم.
لان عندنا سبلين
يعني شنو
يعني
الايرلي ساين اوف
سبلين
هايبرتنشن؟
يعني الفلو
الدايمتر مالته
مالتها
باشكال،
يعني،
الدايمتر مالته
والدايمتر والفلو يعني.
لا هو هسه هذا
نعم
قدامك، الدايمتر مالته باشكال
نورمال
نورمال
within normal.
نورمال. الاوباسيفيكيشن بيها فيلينج ديفكت، اكو سب اوبتيمال
ما شفت بيها
اوباسيفيكيشن،
فولنج،
اكو كولاترالز.
ما شفت
بعد ايش راح يضيف
ولا
لك
شفت
الالترا ساوند؟
كولاترال.
ايش راح يضيف لك الالترا ساوند على الدكتور هذا المريض؟ ما راح يضيف لك هواي شيء عدا الفلو، والفلو مبين بالاوباسيفيكيشن، يعني ما طول صار كونتراست بالبورتال فيس بالاوبتيمال، فاذا هذا اوبتيمال فلو.
نعم استاذ.
طيب شكرا خنساء. كازان،
عشان نعرف استاذ.
كازان موجوده؟
نعم أستاذ، صباح الخير.
صباح الخير. هلا، شنو رايك بالموضوع؟ واكو بعد فايندينج ما شافتها خنساء؟
نعم أكو lung nodule. It is irregular outline at the right posterior lobe, I think.
سوي لانج ويندو.
Yes, it is and irregular outline and with speculated age, mostly this suspicious nodule.
اي زين.
And
اكو عندك نوديول باللور بالرايت سايد باللور لانج. تمام.
Yes, and for further evaluation, I think it's MRI is better rather than
MRI.
CT
MRI for the liver قصدك؟
for liver. Yes.
نعم. زين، سؤال كازان، تتوقعين هذا البيشنت عنده كرونيك ليفر ديزيز؟
Yes.
نعم، عنده كرونيك ليفر ديزيز. اكو جول ستون كانت شفتيها؟
والله بلا زحمة دكتورة مريم ممكن.
اكو جول ستون كانت مريم؟ موجودة جول ستون.
Yes.
موجودة أستاذ
Yes.
جولستون.
Yes.
اكو
Small
جول ستون.
gallstone in the dependent
اي
part.
زين، يعني هسه
Yes.
هذا البيشنت عنده جول ستون
And
وعنده
the
كرونيك
liver is somewhat
كرونيك
heterogeneous
نعم،
liver.
يعني عنده كرونيك
And
ليفر ديزيز وعنده جول ستون وعنده سبلينوميجالي.
وسبلينوميجالي.
نعم، ايش تتوقعين شنو يعني
Yes.
نقدر ناخذ فكرة عن الكرونيك
Um,
ديزيز اللي هي قالت لنا عليه بالبداية؟ أنا كيس اوف كرونيك ديزيز.
maybe chronic liver disease or background of hepatitis or
كرونيك ليفر ديزيز تمام. بعد
I don't know it's male or female.
Female.
Female. So hepatitis most probably.
نعم، كتبوا لك بالتعليقات
And
هيماتولوجيكال ديزيز. ممكن هيماتولوجيكال ديزيز يجمع ذن الأشياء
yes.
كلهن.
نعم.
زين، الالترا ساوند شو يفيدك هنا اوفر ذان السي تي؟ يعني فرضي هسه جبنا الالترا ساوند وشفناه او فحصنا الالترا ساوند، شنو المعلومات اللي راح يعطينا اياها اكثر من السي تي او يعزز لي السي تي؟
It is a non-invasive first modality for evaluation of the chronic liver disease,
Yes.
either size or heterogeneity or elastography for fibrosis and the background of cirrhosis.
liver texture راح will be more clear on ultrasound than on CT.
Yes.
نعم، تمام. هاي شكرا كزان. يلا مريم احكي لنا على الكيس واذا مسويته
شكرا شكرا أستاذ.
Yes, this is an old age female presented because she is on a regular follow-up. She is a chronic liver disease patient, cirrhotic due to hepatitis viral infection. I can agree with my colleagues that the features of cirrhosis is not that clear, but there is some nodularity as you notice here in the lower edge of the right liver lobe, showing an hypodense observation seen at the segment 7 of the liver that is arterially hyper enhanced post contrast, as you can see here, with the size exceeding 20 millimeter. In the delayed phase, there was a non-peripheral washout with retaining of contrast in the periphery. So this observation was diagnosed as HCC, and the LIRADS was given for this lesion as a LIRAD 5. Also, there is some suspicious nodule notice at the base of the right lung, suspicious for metastasis from this lesion, with other features of splenomegaly is also present, and maybe some pelvic settle ascites was seen. So this is a case of a CC.
وهاي النودول اللي باللانج شو اعتبرتوها لو ما علقتوا عليها؟
علقنا عليها أستاذ، قلنا يعني mostly it is a metastatic nodule from the
نعم.
HCC.
نعم. يلا روح على
So
الدور.
we are
وحتى الليفر انلارج يعني
نعم.
هيباتوسبلينوميجالي from the first look يعني.
نعم صحيح.
اوكي.
توك طلع يمكم أستاذ؟
لا
لا بعد هذا بعده موجود.
أسوي ستوب شير وأرجع همينة؟
انا وقفت الشير.
هو
سوي
very-
شير.
هسه؟
ايه
اي
يلا
واضح
تفضل.
هسه.
تمام. So I'm talking about the CT and MR LIRADS. بدأ يقلب يمي. قلب يمكم؟
ايه
Introduction about the LIRAD. LIRAD we all know that the LIRAD is as the thyroid and the BIRAD. It is an liver imaging reporting and reporting system. We will skip the definition and the lexicon of LIRAD, and we will talk about the untreated observation, because LIRAD is concerning about screening, untreated observation, and the treatment follow-up. We will talk only about the untreated observation to guide you for the description of nodules or observations in the liver, and reading and writing the final report about these observations. When to use LIRAD? LIRAD is used for specific subgroups. The subgroups are the cirrhosis patients, cirrhosis that is caused by causes other than the vascular causes, chronic hepatitis B infection, and patients who are known case of SCC. LIRAD, it is not used in patients who are younger than 18 years old, patients who have congenital hepatic fibrosis, or patients who have cirrhosis caused by vascular disorders. After selection of the age and the group that are included in the LIRAD categorization, we are shifting for our study. The study that is used for untreated observation, they are MR or CT scan. The protocol should be checked before including the patient in the LIRAD system. So you are dealing with MRI. The MRI should include T1 in phase and out of phase image, T2 with or without fat suppression, multiple T1 pre and post contrast, optional sequences such as diffusion weighted images, and subtraction images. CT scan should include late arterial phase, portal venous phase, delayed phase. Pre-contrast images are only recommended after loco-regional treatment. So we have major features that are seen in an observation that are definitely or reaching in the diagnostic possibility of 100% that this observation might be SCC. What are these major features? The major features are 5 major features that are typically seen in the HCC. First one is the arterial phase hyper enhancement, which is a non-REM arterial phase hyper enhancement of an observation. You can see that we are using the term observation more than the term of a nodule or a lesion or a mass, because in the cirrhotic patient there might be some hyper enhancement, some fatty sparing region. These are all included in the LIRAD categorization, other than the usage of the term nodule or mass. The enhancement of arterial phase hyper enhancement should be non-REM hyper enhancement and should be greater than the background liver. The washout should be non-peripheral washout, i.e. central washout. The capsule should be smooth, uniform border surrounding all or most of the observation. The size, the large observation has a greater chance of being SCC than the smaller observation, and the cutoff point is the 20 is better, more than 20 to consider it as an SCC. The threshold of growth is increasing in size of 50% or more within a 6-month time during the follow-up. Here we can see that there is non-peripheral arterial phase hyper enhancement, non-peripheral washout, the presence of capsule which should surrounding all the lesion, and the threshold growth, which is an increase in the size of the lesion 50% in the 6-month follow-up. Arterial phase hyper enhancement, we can see in this small image, I think, for you, but it is clear that there is some hyper enhancing, centrally and peripherally hyper enhancing lesion in arterial phase in this liver, which after demonstrating the same lesion in the delayed phase, there is a washout, which is a central washout and retention of contrast in the periphery. The capsule, as we can see, this is a capsule capsule that is surrounding all on observation. The size of the lesion better to be more than 20 millimeter, and if it is not more than 20 millimeter, follow up within 6 month period, showing that this hyper enhancing observation was increasing in size after follow up. So we are done with our major features. There are some ancillary features. I think this ancillary features are somewhat confusing and need some concentration to understanding these ancillary features. The ancillary features are helpful in the detection improvement and increasing the confidence favoring the diagnosis of SCC versus non-SCC malignancy or confirming the benignity. These features are not obligatory. I mean that there some patients you cannot use the ancillary features for them. Others can be use the ancillary feature for. In case the category adjustment, I mean, you see the major features and you shifting to the ancillary features, and the ancillary features was present in the same patient you are evaluating, you can upgrade or downgrade the observation according to the ancillary features I will tell you about in a few seconds. But the ancillary features can upgrade the patient from L3 to L4 easily, not from L4 to L5, because the LIRAT 5, it is confident, you must be confident and 100% sure that this is an SCC, and the ancillary features are not definitely features of an STC. It is only a helpful feature for upgrading the observation from L3 to LR4, or from LR1 to LR2, or LR2 to LR3, not from LR4 to LR5. These ancillary features are three subgroups. Either features that are favoring SCC, or features that are favoring malignancy other than SCC, or features that are favoring the benignity. Features that are favoring SCC, I think these are the most important and the most easily to be memorized, other than the features that suggesting malignancy other than SCC. Features of favoring SCC are non-enhancing capsule, nodule within nodule, mosaic architecture, blood product in the mass, and fat in the mass more than the liver. As we can see in these images, that this is an observation with nodule within nodule, and this observation is a mosaic attenuation in post-contrast imaging. The features favoring something other malignant, but it is not HCC, it is that the nodule or the observation is visible in the ultrasound, subthreshold growth. We said previously that the growth should be more than 50% in 6 months, but if it is less than 50% in the follow-up of 6 months, we call it a subthreshold growth. The restricted diffusion, it is seen in the SCC and the malignancy other than SCC, but in the ancillary features it was labeled in the features of malignancy other than SCC, mild or moderate T2 hyperintensity, coronal enhancement, meant by it there is vascular hyper enhancement surrounding the lesion, solid mass that is not containing fat or not containing iron, transitional phase hypointensity, and hepatobiliary phase hypointensity. Ancillary features that are favoring benignity are the size, stability more than 2 years, size reduction, enhancement paralleling the blood pool as seen in hemangioma, undistorted vessels, iron in the mass more than that of the liver, marked T2 hyperintensity, and hepatobiliary phase isointensity. I'm sorry. What are the LIRAS category that helpful in usage in the reporting system? LIRAD 1 and LIRAD 2. LIRAD 1 is definitely benign, and LIRAD 2 is probably benign. I think they are similar. They are cyst, hemangioma, perfusion alteration, hepatic fat deposition or sparing, hypertrophic pseudomas, confluent fibrosis, or focal scar. As we can see here that there is observation hypo enhancing and not affecting the adjacent vessel. This is diagnosed as a fatty lesion in the liver. Why we are not using the same, there is LIRAD 1 and there is LIRAD 2. LIRAD 2, it is probably benign because when you have some suspicion and you are not sure about it, this is a benign or not benign, you put it in LIRAD 2 because 16% of LIRAD 2 are SCC and 18% are malignancy other than SCC. This case, you can see this is a hyper intense lesion or observation seen in the cirrhotic liver in T2 weighted images that is enhancing post-contrast. But the source image was hyper intense in T1. So this was a suspicious feature, and you can put it in LIRAD 2. LIRAD 3, it is intermediate probability. Of all the LIRAD lesion, approximately 37% are SCC and 39 are malignant other than SCC. The observation with features of focal nodular hyperplasia and hepatic adenoma are demonstrated in the LIRAD 3. The nodules of less than 20 millimeter without major features but with one or more ancillary findings of malignancy, or nodules that are above 20 millimeter and without major ancillary feature. As we can see, this is an arterial phase hyper-enhancing observation seen in a cirrhotic liver. In the portal phase, there was a non-change, and in the delayed phase, there was some washout. Maybe it is not so clear in the talk. The LIRADS 4, it is probably SCC. Of all LIRADS observations, 74 are SCC and 81 are malignant other than SCC. Categorization and observation as a LIRAD 4 depending on the size of the lesion and the presence of arterial hyper-enhancement and the amount of additional features. And there is a hyper-enhancing observation that is seen in the segment 7 of liver with the central washout in the delayed phase, and this was labeled as LIRAD 4 observation. LIRAD 5, you should mention that there is observation with definitive or major features of the SCC to put it under the label of LIRAD 5. The lesion should be more than 20 millimeter, non-REM arterial hyper-enhancement and washout. As we can see that there is large lesion occupying the right lobe of the liver, hyper-enhancing in the arterial phase, central and non-peripheral washout in the delayed phase. So this was labeled as LIRAD 5. We are now confused. Which is which? Which is LIRAD 5? Which is LIRAD 4? So there was some table that is helpful, and you maybe put it in your pocket or your phone to make it easier for you to categorize the observations. How to use this table to make it easy for me to categorize the lesion. Is it LIRAD 3, LIRAD 4, or LIRAD 5? First, we should determine the type of the enhancement. You see an observation in a cirrhotic patient in the liver. Identify the type of the enhancement. Is it hypo-enhancing, iso-enhancing, or it is arterially phase non-REM hyper-enhancement? Then looking for the size of the lesion. The size of the lesion, if it is for example, you are dealing with an arterial phase hypo-enhancing lesion, that the size of this lesion is less than 20 millimeter, then you should look for the additional typical features. The additional typical features are the capsule, the washout, and the growth. If there is none of these three features present for the observation and the lesion is less than 20 millimeter and it is arterially hypo or iso enhancing, so this is a LIRAD 3. and so on. If there is additional feature of capsule, presence of capsule, or presence of washout, or presence of the growth, shift it for LIRAD 4. More than 2 features shifting the lesion to LIRAD 4 for the same size and the same arterial hyper-enhancement. But there is some thing here I want to undress it, that there is a box here that you can see is somewhat confusing. Is it LIRAD 4? Is it LIRAD 5? It is actually depending on the type of the additional feature. So you are dealing with arterial phase non-REM hyper-enhancing lesion, and it is of a size 10 to 19 millimeter. And it is having a one additional feature, capsule, washout, or growth. If the additional feature is a capsule, label it under the LIRAD 4. If the lesion is washout or growth, label it as a LIRAD 5. Additional categorization is the LRTIV, that is a tumor in vein. If you are see some lesion that is invading the vein, you can label it in this category. LRM, which is a malignancy but other than HCC, LRT, that is a treated HCC, and LRN is NC, that is non-categorizable. For example, patient with multiple phases and contrast enhancement. This study is not categorizable in my LIRAD system, so you can label it as a non-categorizable observation or lesion because of technical quality of the images that does not allow the evaluation of the major features. Tumor markers, we all know that the AFB is goes more with HCC. So if the AFB level is more than 100 nanogram per ml, it is moderately high and moderate high probability of HCC. If it is more than 200 nanogram, it is high probability of HCC. I mean, it can be helpful in upgrading or downgrading the LIRAD. الليبل يعني التيومر ماركر الآخر هو CA19-9, which is if it is more than 100% or more than 200%, and we know that this tumor marker is has a moderate or high probability of intrahepatic cholangiocarcinoma. Before we are finishing, the follow-up expected for the patient that you're giving a category of non-categorizable or LIRAD 1 or LIRAD 2 or 3 or 4. In the report, you should mention that the follow-up of the patient that you are wishing for him. For example, if he has a LIRAD 1, you give him a returning for a surveillance in 6 months. But if he is a LIRAD 5, you should advise for multidisciplinary discussion for the management, or if it is LIRAD M, multidisciplinary discussion considering biopsy, or if it is tumor, you expect that the patient will go for a biopsy. And the last, I want to give you a roadmap to walk through it in a cirrhotic patient that is more than 18 years old in age, or hepatitis B infection, or has history of HCC. This is included in the criteria that can be categorized by the LIRAD. If this patient has a study by MRI or CT, look for the phases and the sequences. If these phases and sequences are sufficient and satisfying for you, then shift for applying the diagnostic algorithm of the LIRAD, I mean the major features. The major features categorized, then shift for the ancillary features, because the ancillary features will help you to upgrade or downgrade the lesion, and it is named as a tie breaking. I mean, breaking the rules. If you need to draw the physician suspicion more about the observation you are seeing in your imaging. These are the references, and thank you for your listening.
شكرا جزيلا